Good day, everyone. This is Jim Moeller. I'm the director of the Sports Medicine Fellowship Program at Henry Ford Health System in Detroit, Michigan. And today we are going to address another medical issue in sports medicine, heat illnesses. The goals of today's talk are to review the epidemiology of heat illness, review the different levels of heat-related illness in athletes, discuss the clinical findings encountered in various levels of injury, and discuss the treatment of heat-related illnesses. It is estimated in the United States that heat-related illness accounts for nearly 700 deaths per year. These are not just sport-related heat illness deaths. Death from heat illness is more common in the elderly, more common in males, more common in the months of July and August, as would be expected, and more common in certain regions of the country. California, Texas, and Arizona account for 43% of the total. Here is a graph showing the number of heat-related deaths from 1999 to 2009. Males and females follow the same pattern. Clearly, the over 65 age group is most at risk. When we talk about death from heat-related illness in athletes, we're really looking at this age group here, where it seems to be much less common. But every year we do encounter heat-related deaths in athletes. In high school, it is estimated that over 9,000 time-loss heat-related illnesses are noted annually, with most of these coming in football. Football is 10 times more likely to produce heat-related illnesses than any other sport. The rates are similar in both practices and games, and it's most common in August during the preseason training. The majority of these athletes return to play within 1 to 2 days. Here's a graph showing the numbers of heat-related illness in football compared to other sports. Interestingly, girls volleyball has the highest number of heat-related illnesses for females, and this is an indoor sport in the fall. When looking at heat illness in high school athletes by month, we can clearly see that August has the most heat-related illnesses. And this makes sense because high school sports don't even start in the fall until August. And across the country, August is the hottest month. So when we talk about heat illness, we have to consider thermoregulation. Thermoregulation is the body's ability to maintain a constant temperature. To accomplish this task, there are 4 forms of heat exchange: radiation, conduction, evaporation, and convection. Radiation is the transmission of electromagnetic waves from the body. Conduction is the transfer of heat between warm and cool objects by direct contact. Convection is heat transfer by air or liquid circulation, and evaporation is sweat on skin surface turning to vapor. Here is a busy graphic showing how thermoregulation works. I would advise you pause the lecture here and take a close look at this graphic, as we will not be explaining it in detail. Here is a common board question. What is the predominant mechanism of body heat dissipation in an athlete performing intense exercise in a warm climate? The answer is evaporative heat loss. The risk factors for developing heat illness can be divided into internal factors and external factors. Athletes can control some of the risk from internal factors by getting enough sleep, properly hydrating, being in good cardiovascular fitness, avoiding certain medications and supplements, and making sure they get enough sleep. When it comes to external factors, this is where decisions by coaching staff and medical staff come into play. Let's look at wet bulb globe temperature. This determines the saturated immobile air temperature, which could impose an identical thermal load as the actual environment. Ambient dry air temperature, which is the thermometer temperature, true capacity of air to evaporate water according to its relative humidity and air velocity, which is the wet bulb thermometer, and solar radiation, which is the globe thermometer, are included in this calculation. Here you see a handheld electronic device for wet bulb globe temperature. In the past, a sling psychrometer was used. Risk factors for a high wet bulb globe thermometer reading include high ambient temperature, which leads to reduced conductive heat loss from skin to air, high humidity, which leads to reduced evaporative heat loss due to high air water vapor pressure, reduced wind, which decreases the convective heat loss, and a clear day, which increases the radiant heat from the sun. Once this temperature is determined, we can determine the risk level for heat illness. If we are in the low risk category, it's a green flag day, and the risk is low but still exists on the basis of intrinsic risk factors. If we have a moderate risk level, it's a yellow flag day, where the risk level increases as the event progresses throughout the day. If we are in the high risk category, it's a red flag day, and everyone should be aware of injury potential, and individuals at risk should not compete, although competition still may go on. And finally, if it's an extreme risk level day, it's a black flag day. And this is when practices or games should be either rescheduled, delayed, or canceled for the safety of the athlete. If one does not have a wet bulb globe thermometer, the temperature can be estimated based on the ambient temperature and relative humidity. And here is a graph that shows this. If, for example, the ambient temperature is 86 degrees and relative humidity is 50%, we fall into a moderate risk day or a yellow flag day. So if we go back to our list of internal and external risk factors and think about those internal factors that are more commonly seen in young athletes: dehydration, prior history of heat illness, use of medications and supplements, obesity, overmotivation, poor acclimatization, poor cardiovascular fitness, and sickle trait are the ones that are most commonly encountered. So let's talk about heat illnesses. You can divide heat illnesses into mild, moderate, and severe problems. Mild problems include heat edema and heat rash. Moderate issues include heat syncope and cramps, and the severe issues include heat exhaustion and heat stroke. Heat edema is mild edema of dependent extremities. It's due to vasodilatory pooling. Body temperature is normal, and this resolves with rest, removal from heat, and elevation of the affected extremities. And you've all experienced this if you wear a ring and you exercise in the heat and you can't get your ring off. When you get back into the air conditioning and rest for a little bit, the ring then is able to slide off your finger more easily. Heat rash, or prickly heat, whose clinical name is miliaria rubra, is a pruritic papulovesicular rash over clothed areas. Again, the body temperature is normal. These are mild heat illnesses. The mechanism is trapped perspiration causing skin inflammation, and this usually resolves spontaneously, but calamine lotion, antihistamines, and oatmeal bath can be helpful in making this go away quicker. When we get into the moderate forms of heat illness, we start to talk about heat syncope, which is also referred to as exercise-associated collapse. You'll see this at the end of endurance races, where the athlete sprints to the finish line, comes to a stop, and then collapses. The body temperature is normal. This process is caused by vascular pooling. At the end of the race, the lower extremity muscles are no longer pumping blood back up to the heart, and so there is pooling in the lower extremities. This is compounded by dehydration, and the athlete becomes lightheaded, dizzy, they faint, and that's when you're called into action. If the athlete does not completely pass out, they often cannot stand on their own. Again, this occurs after crossing the finish line. because while they're running, they're still using the muscles as an active pump to keep the blood in circulation. Treatment is to rule out heat stroke and exertional hyponatremia, place the athlete supine with legs elevated, and start PO rehydration if they are able. If they are unable to drink, then IV fluids may be needed, and regular monitoring of body temperature and mental status is important to make sure that they're not progressing into a more serious form of heat illness. When you talk about heat cramps, we're talking about severe widespread muscle spasms in large muscle groups. Body temperature is normal or could be mildly elevated. This is more commonly seen in salty sweaters. You can see from the picture on the right the salt lines from the sweat that has dried on the cap and shirt. Other risk factors include high volume sweaters, dehydration, and the use of hypotonic fluid replacement in long endurance events in the heat. Treatment of heat cramps includes ice, massage, passive stretching, salt supplementation, and it's usually a good idea to get them out of the direct heat source as well. You should have a low threshold to rule out rhabdomyolysis in these patients. Moving on to the more serious heat illnesses. Heat exhaustion. This is characterized by tachycardia, muscle cramps, nausea and vomiting, dizziness, and syncope. Mental status is intact. The body temperature will be elevated but stays below 40 degrees centigrade or 104 degrees Fahrenheit. You have to be very cautious because this may progress to heat stroke. The dizziness and syncope of heat exhaustion often occurs during the race. This is different from exercise-associated collapse or heat syncope, where typically the athlete will finish the race and then collapse upon completion. In cases of heat exhaustion, measurement and monitoring of core temperature is important. The question becomes, how do we measure temperature in a collapsed athlete? Do we use rectal temperature, oral temperature, or some other type of central monitoring device? When we consider temperature measurement, we have to think about the ease of measurement, make sure that the method is unaffected by external environment, and also make sure that the method is accurate and consistent for the diagnosis and monitoring of core temperature during treatment. The gold standard temperature measurement would be a core temperature, which would be esophageal, GI, pulmonary artery, or urinary bladder measurement. Other options include rectal temperature, oral, axillary, tympanic membrane, temporal, and wearable technologies. The wearable technologies are radiometric thermographic devices that measure radio waves emitted through the skin. Of these options, the validated measurement devices are those that measure esophageal, GI, and rectal temperature. When you consider what we discussed previously, rectal temperature is the clinical method of choice. But to get an accurate core temperature or equivalent to core temperature using a rectal thermometer can be difficult. Here is a study performed out of Central Michigan University and the University of Connecticut that looked at 17 subjects, 14 of whom were male, and compared esophageal temperature to rectal temperatures at various depths, measured at rest, during exercise, during cold water immersion, and after immersion recovery. Athletes exercised until their core temperature hit 39.5 degrees centigrade, and then they were put in a cold water immersion bath until temperatures were less than 38 degrees. In order to get the most accurate comparison to core temperature as measured by the esophageal temperature, the rectal probe had to be inserted to a depth of 15 centimeters. This is 6 inches. This type of measurement would be difficult at best in a downed athlete. When heat exhaustion has been diagnosed, The treatment includes discontinuation of the activity, which usually takes care of itself, removal of clothing and sports equipment that restrict heat dissipation. You want to relocate the athlete to a cool, shaded area, put them supine with the lower extremities elevated, and if able to oral rehydrate, do so, but IV fluids may be necessary. You want to monitor the rectal temperature, vital signs, and mental status. And if the temperature is elevated, you start external cooling. And as we said, in most cases, the temperature will be elevated but will be below 104 degrees Fahrenheit. External cooling methods include ice towel application, the cold burrito, ice water immersion, and you should consider transfer to the hospital if the core temperature rises above 40 degrees centigrade, because now you're getting into the temperatures of heat stroke. Mental status changes also may signal the change to heat stroke, and if there is concern for rhabdomyolysis. There is no clear or validated guideline regarding return to play, although common sense would suggest that individuals should abstain from exercise for at least 24 hours after resolution of all symptoms and lab abnormalities. The most serious of heat illnesses is heat stroke. This is a medical emergency. The hallmarks of this disease process are a core temperature greater than or equal to 40 degrees centigrade and mental status changes. This is in conjunction with the signs and symptoms that are seen in lesser forms of heat illness. Heat stroke may lead to severe central nervous system dysfunction, severe rhabdomyolysis, multi-organ damage, and death. When you look at the number of heat stroke deaths in the United States in 5-year blocks over time, you can see that the numbers vary from block to block. Looking from 2010 to 2014, in 2010 there were 4 cases, 2011 5 cases, and then 1, 0, and 3 cases in 2012, 13, and 14. When you look at the final block on the right, this is only 4 years of data. The 2019 numbers were not in yet. When you have diagnosed a patient with heat stroke or have serious concern for heat stroke, the number one thing to do is reduce the core body temperature. In fact, the top 3 treatment options at this time are reduce the core body temperature, reduce the core body temperature, reduce the core body temperature. Prompt recognition of the disease process and initiation of cooling is paramount for recovery. Survival is virtually 100% if cooling is initiated in less than 10 minutes. Some reports state that there's 100% survivability if cooling to less than 104 degrees Fahrenheit is achieved in less than 30 minutes. The longer the athlete is exposed to elevated temperatures, the greater the complication rate. So again, it's paramount that we begin cooling as soon as possible. Cold water immersion is the treatment of choice. In fact, when you compare cold water immersion to other cooling methods, we find that the time to cool to target level is significantly faster with cold water immersion compared to ice sheets and other cooling devices. The data you see here is from a study that was performed in a randomized, repeated measures design. The participants exercised in an environmental chamber where they followed a military march protocol on a treadmill, and this was followed by the application of one of the 3 treatments. Cold water immersion is the cooling method of choice for exercise-related heat stroke. But what if cold water immersion is not available? There are other cooling options that you can utilize. Misting fans, ice packs to the neck, groin, and axilla, the cold taco or burrito, where you wrap the individual in ice sheets. It is important to monitor core temperature during this time and continue cooling until the core temperature is between 101 and 102 degrees Fahrenheit. All of these patients need to be transported to the hospital for cardiac monitoring and laboratory evaluation. They also may need cold IV fluids as part of their treatment. It is important that we don't waste any time while we're waiting for transport to take place. We want to be utilizing that time to actively be cooling these athletes. So start the cold water immersion even before the ambulance shows up. Also, I didn't mention that we have to make sure that we are supporting the athlete. They are often under a situation where they have altered mental status and may not be able to protect themselves. So we have to make sure that we hold their head out of the water. We don't want to complicate their heat illness by adding drowning into the mix. The use of cold IVs has been shown to reduce the length of hospital stay by 1 day in patients with heat stroke, and it has shown to reduce the peak creatine levels found. So the use of cool IVs can certainly be of benefit. There is no comprehensive or validated guideline for return to play after heat stroke. You have to remember these athletes are now at increased risk for future heat illness. Expert consensus advises at least 7 days prior to consideration of initiation of return to play in, quote, mild cases. But in my eyes, there is no such thing as a mild case of heat stroke. Certainly, there has to be a normal physical examination, and all laboratory values need to be in the normal range. Activity should be initiated at low intensity and in cool environments to allow the athlete to acclimate, and this advances gradually over 2 to 4 weeks till they return to full play. Prevention is key. We have to educate coaches and players not only on the signs and symptoms of heat stroke, but on the risk factors that lead to heat stroke. We have to allow our athletes to acclimatize to exercising in the heat. Wearing light and light-colored clothing can be helpful. We have to reduce the use of equipment that can block heat dissipation during the initial week of preseason. It is probably best to limit the two-a-days in the early preseason, as this is the time of the year where most heat illnesses occur. Allow them to take frequent breaks in the shade and provide plenty of fluids. When environmental conditions dictate, we have to change the practice plan and/or time to allow for practice in a cooler time of day. And we also have to have an emergency action plan at the ready in case one of the athletes starts to show signs of heat stroke. Let's talk about some potential board questions associated with heat illness. During the second football practice of the day on day 3 of the college preseason football camp, an offensive lineman is found sitting on the ground, unwilling to stand up. He states that his left calf is cramping and that he feels lightheaded and exhausted. You suspect possible exertion heat stroke. Which of the following statements about this condition is true? 1. Axillary, oral, or a rectal temperature greater than 40 degrees centigrade establishes the diagnosis. 2. This condition occurs randomly without warning and cannot be predicted. 3. Cold ice water immersion is an effective way to treat exertional heat stroke. 4. There are 2 patterns of presentation: sodium depletion and water depletion. Pause here while you think of your answer. The answer is cold ice water immersion is an effective way to treat exertional heat stroke. Another question. You are evaluating an obtunded athlete who collapsed toward the end of a marathon. Physical exam is significant for rectal temperature of 98.6 degrees, blood pressure 110/60, heart rate 110, and diffusely increased muscle tone. What is the most likely diagnosis as you prepare to have your athlete transported? One, heat stroke. 2, myocardial infarction. 3, rhabdomyolysis. Or 4, exercise-associated collapse. Pause here as you think of your answer. The answer is rhabdomyolysis. The screen is having difficulty advancing right now. Heat stroke would be associated with a significant elevation in core temperature. Myocardial infarction would be usually associated with some changes in blood pressure or heart rate. And exercise-associated collapse is a situation in which they cross. Children's sweat rates are equal to adults and therefore are not at greater risk. Children usually stop before they get too hot and therefore are at no greater risk than adults. Children don't absorb fluids as readily as adults and therefore are at greater risk than adults. Or children have increased heat production per kilogram of body mass and are at greater risk than adults. Pause here while you think of your answer. The answer is that children have increased heat production per kilogram of body mass and at greater risk than adults. I again apologize, the slide is having difficulty in advancing here. When we talked about the intrinsic risk factors, we know that age under 15 is a risk factor for development of heat stroke. Here is a similar question which showed up on a CAQ exam. Children are a population at risk for heat-related injuries because of which of the following? 1. Children sweat more and are thus at increased risk for dehydration. 2. Children have a lower surface area to body mass ratio and consequently dissipate heat less efficiently. 3. Children produce higher temperature elevations because they tend to generate more heat secondary to higher percentage of adipose tissue. Or 4. Children have higher surface area of body mass ratio, which may cause a higher absorption from ambient environment. And the answer is that children have a higher surface area to body mass ratio, which we talked about in the previous question, which may cause a higher absorption from the ambient environment. Children actually sweat less than adults and require greater core temperature to increase their sweating mechanism. They also acclimatize more slowly. I'll start the next question as we're having some trouble advancing the slide again. It is well known that weather can play a significant role in the outcomes of endurance races. Which wet bulb globe temperature is the threshold that would want a black flag warning on race day? Is it 78 degrees, 88 degrees, 82 degrees, or 85 degrees Fahrenheit? The answer is 82 degrees Fahrenheit. I'll take you back to the graph that we showed during the lecture. If you remember that 18 degrees centigrade and 28 degrees centigrade are the extremes, and then you divide the central portion into two pieces, that's the way you're going to best remember the wet globe bulb temperature amounts that change you from low to moderate to high to extreme risk. The next question, again, I will start. Okay, here we just switched. Good. I apologize for the typos as well. I'll go ahead and change these for future lectures. The body essentially loses no heat when the temperature is approximately above what degrees centigrade Fahrenheit, and the humidity is above what? And the answer is 35 degrees centigrade or 95 degrees Fahrenheit and 90% humidity. Again, this question was lifted straight from the CAQ review book and was a question that appeared on a past CAQ. Basically, what this is saying is that once you hit this temperature and humidity, the body will not dissipate heat any further, and the risk of heat illness starts to go up accordingly. Heat cramps are primarily related to the loss of which electrolyte? Now, we did not specifically discuss this. Potassium, magnesium, sodium, or chloride? And the answer is sodium. What is the hallmark of heat exhaustion? Is it increased environmental temperature, total body salt deficiency, hypovolemia, or hyperthermia? And the answer is hypovolemia. Remember, in cases of heat exhaustion, Temperature is often elevated, but not necessarily to a high degree, such as that seen in heat stroke. It can occur on cooler days if the humidity is high. And one of the keys to treatment, aside from external cooling, is replenishing fluids. What is the hallmark of heat stroke? Increased environmental temperature, total body salt deficiency, hypovolemia, or hyperthermia. And the answer is hyperthermia. As I just mentioned, the core temperature over 104 degrees is the hallmark of heat stroke. Another question from the board review book. You are the race physician at a summer race in Georgia. First of all, maybe have it in the spring or late fall. An athlete is brought in by the field team to the medical tent. Pulse is 165. They are semi-comatose. Rectal temperature is 42 degrees centigrade. Skin is flushed, but not sweating very much, and they look hot and dry. What is your first step? Aspirin is all that is necessary. Remove the subject to a quiet, shaded place. Place wet towels around the neck and groin region. A cold shower and sponge rub down with rubbing alcohol. Help the patient drink some very cold fluids, at least 1 liter. I'm sorry for the autocorrect typo there. Or 3 to 4 liters of cold IV fluids immediately. We have a little, there we go. And the answer is 3 to 4 liters of cold IV fluids immediately. This patient has heat stroke. And as we discussed before, the administration of cold IV fluids can be beneficial in recovery, reducing length of hospital stay, and so on. If there was an option to select cold water immersion, that would have been the correct answer. But again, this specific question was taken directly off of a CAQ prep book. This was a question that did appear on the CAQ in the past, and so I wanted to present the question as it appeared. But again, if cold water immersion was an option, that would be the correct choice. So I thank you for your time and attention during our discussion today. I apologize for the typos. I will go back and correct those. I hope someday we will all be able to meet in person, and I hope this lecture series has been helpful for you. In the meantime, have a great day.